Well, good afternoon, everyone. Thank you for joining us here for this session. This is the Rural Generalist Training session. The purpose of this particular session is to reflect on the training and retention of rural generalists. We've been talking about a few themes throughout the conference over the last couple of days that seem to appear, and that is things like keeping the training while rural, looking at opportunities to go out there. That was certainly one of the key themes out of the comments out of the President's breakfast this morning, and the support services to keep doctors out there and engaged as rural generalists. So on the panel today, joining us is our premium sponsor from Rural Workforce Agencies. Please make her welcome, Megan Carl. Also on the panel, the Executive Director of Queensland Rural Medical Service, Hwee Chong. And to start our presentation, so what we'll do is we'll do the presentation from the speaker, and then they'll sit down, and then the second presentation will come up, they'll sit down, and then I'll open the floor to questions from everyone to the panel. Please welcome the Research Fellow and MCCC GP Training, Dr. Tim Clement.
Thanks very much. I'm not talking about rural generalism. I'd like to acknowledge the Larrakia people as the traditional owners of the Darwin region. I pay my respects to the Larrakia elders, past and present, and extend that respect to any other Aboriginal people who are in the room. I'd like to recognise the contributions of my colleagues, Professor John Loughran and Drs. Duncan Howard and Eldon Lyon, and the research funding from the Australian College of Rural and Remote Medicine. So in the Australian General Practice Training Program, GP registrars work independently under the supervision of a designated supervisor, someone who has content knowledge of the specialty, but does typically not have a teaching qualification. A broad interest of mine is the teaching that takes place in the AJPT training posts, and we make the distinction between ad hoc supervision and protected teaching. The former is generally required when a registrar is consulting and judges that he or she is not confident to manage the consultation independently. This is the kind of ultimate teachable moment. Previous research in this area sparked my interest in looking at the other form of teaching, protected teaching. And in their first year of training, registrars typically receive 1 hour of teaching that is private and free from interruptions. This is generally conducted by the supervisor, is typically one-to-one, although can involve a small group of learners. And although it's a significant space for teaching and learning, it has been little researched. At MCCC and at Southern GP Training, for whom I previously worked, the content and style of teaching sessions are left to the discretion of supervisors. I don't believe that there's one best way to organise this teaching, but a common practice is for registrars to bring along cases that they have questions about and want to discuss, presenting supervisors with another teachable moment. And it's one that they typically have to react to, an extremely challenging state for any educator. And just to get you in the educator's frame of mind, here's an authentic question posed by a registrar in this project. Anyway, so what have you got there anyway? The only question I had was, I was trying to remember, with carotid artery stenosis, if they're less than 75%, you wouldn't send them to a surgeon for a CEA. It would be an interesting exercise if this were a workshop and we had the time to ask you with an educator's hat on how you would respond to that question. Unfortunately, we don't have the time. So I need to tell you about the concept that underpins this research. I'm only going to say this once: pedagogical content knowledge, from henceforth PCK. It's been well researched in the mainstream education, but not in the medical education sphere. Its roots go back to the 1980s and to the work of Lee Schulman. There's a lot in this particular quotation that requires unpacking, but essentially PCK is the educator's understanding of how they blend specific content and pedagogy to teach particular learners. And Lee Shulman claimed that PCK is the category that is most likely to distinguish the teacher from the content specialist. For me, PCK offers an exciting way of investigating the teaching practice of supervisors, of investigating the relationship between their understandings of subject content and the instruction that they provide. There's been many attempts to depict the knowledge that educators need to be effective teachers. This is a recent model of teacher knowledge and skill with PCK embedded within it. Again, we haven't got time to unpack the model, but the important inference that we can make is that teaching is complex and challenging. This is important in framing the research because PCK is a vision of expert teaching. If you know your content and you know your pedagogy, you're making decisions about why you do things in particular ways with that content. So we wrote an overarching question and 3 sub-questions, and we believe that understanding how supervisors think about what they do during protected teaching provides a route into improving practice. The first sub-question reflects that blend of content and pedagogy in the definition of PCK, and the second asks whether we can kind of represent that PCK in a way that's accessible to other people. I'm going to gloss over the research design, but I'm happy to take questions or comments in the discussion. So video recordings of teaching sessions and a subsequent stimulated recall interview are really the kind of core data of the things that we looked at. In addition to 8¼ hours of observational data, we had 9½ hours of video recordings of protected teaching. We broke up the video recording data into smaller segments, which we named episodes, and then categorized each episode by its particular focus, creating 11 top-level categories, with 2 categories accounting for 79% of the total number of categories. So 124 of the 157 episodes focused on professional knowledge, skills and abilities and the management of the protected teaching session. We broke the largest category, professional knowledge, into 4 subcategories reflecting different foundations, whether the kind of basis of the teaching was real or hypothetical patients or topics. Now, this actually wasn't one of our primary research questions, but it is quite useful to be able to describe the types of activities that happen in protected teaching. And the contact log that we created for each supervisor we used to select particular episodes that we interviewed them about. So in addition to the earlier question, here's another extract from a teaching session, and we used the actual video recording to ask supervisors to explicate the teaching that followed. But the thing I said to you is that when you have those classic symptoms of loin pain radiating to the groin, but particularly when with testicular pain, consider visualizing the kidneys, consider getting an MSU done. Well, the MSU is fine. And the other thing on the ultrasound was a right-sided simple cyst, and I wanted to know, I don't really have a framework on working through renal cysts and renal things like that, another of these sort of questions. So Harry Walcott suggests that description, analysis and interpretation are the 3 primary ingredients of qualitative research. I'm going to concentrate on interpretation in relation to the first of the sub-questions that we asked. I'm going to highlight some findings and ask what is to be made of them. In doing so, I may reach beyond the data, but I suspect that this may be more of interest to you, and you can judge whether what I'm saying has any relevance to your own contexts. So case studies for me demonstrate that something is possible. The general statements that follow can be illustrated for data, with data which I don't have time to present. So in the main, we would suggest that PCK, this concept of expert teachers, was absent from the teaching that we observed. When it was present, the teaching was topic-based and delivered by only 2 supervisors who also happened to be medical educators for our organisation, who also happened to have a specialist teaching qualification. We would characterise the teaching that was not PCK as reflecting a teacher-centred orientation, typified by the transmission of knowledge. where the supervisor is the expert who shares her greater knowledge rather than teaching about it. We classified 65% of the content of the teaching sessions as being related to this kind of professional knowledge domain. And it might be the case that the focus on content of this type is linked to that particular style of teaching. The notion of filling in gaps was also surprisingly common for such a small sample. The action of the supervisor filling in the gap is also congruent with teaching as the transmission of knowledge. Typically, when teaching was not PCK, supervisors were usually reacting to a registrar's agenda that was unveiled during the teaching session, usually in relation to a patient that the registrar wanted to discuss. And again, this is teaching in the moment, which I said is a really challenging place to be. When the teaching was not PCK, we characterized much of the observed teaching as being habitual, adopting instructional strategies unconsciously. Supervisors were drawing on their general pedagogical knowledge rather than asking, how am I using this instructional strategy in this instance? So the data also shows that PCK is possible, but the stronger pattern is just as I've described. So why didn't we see more PCK from these sample of experienced supervisors? And our intention is not to condemn our supervisor participants or supervisors in general. If we go back to the definition of PCK, it's a definition of expertise, a definition of a teacher rather than a content expert. I'm going to flag two possibilities and then move on because I don't believe the explanations to be valid. Firstly, as teachers' professional knowledge is generally tacit, the methodology that we use wasn't good enough to uncover it. That's one possibility. Or secondly, that PCK is a concept that is suited to teacher education, but not to general practice medical education. More likely, I think, are these explanations. So I framed teaching as complex and challenging work. Yet in the general practice environment, the underlying operational assumptions are that it is simple, intuitive, doesn't require much time, and that you can learn to be a teacher by teaching. That any willing GP with their clinical knowledge and a smattering of general pedagogical knowledge can do it. And in order to be a supervisor, you merely have to meet eligibility criteria, not competency standards. So having time for registrars to discuss patients about which they have dilemmas is an important part of protected teaching. Yet if this is the only thing that happens, then the supervisor may not get to teach in a meaningful way or tap into their PCK. If the perceived purpose is to fill that knowledge gap and to make sure that the patient is safe, then they may not push beyond those immediate tasks. So being a teacher is just one of the sub-roles expected of supervisors, and they face a challenging task of balancing service and teaching. The imperative for patient safety makes it easy to prioritize service, of solving the patient's problem, a role that they are likely to feel more comfortable in. But it's not either or. Supervisors are doctors, but they are also teachers of doctors. So teaching requires time for planning, and planning is more than having an outline structure for the session. It's more than having a list of activities. Planning hints at some thoughts about goals and how to meet those goals. In the AGPT program, planning time is not specifically funded for supervisors. And in a busy general practice environment, it is unlikely to take place if we are asking supervisors to plan in their own time. Teaching also requires time for reflection, and the demands that we place on supervisors create a focus on doing teaching rather than explaining their reasons for what they are doing. And without time for reflection, supervisors' conceptions of learning and teaching may remain unexamined. Experiential knowledge is also prized in medicine, yet there are limitations of learning from experience. It is not as effortless as people might like to believe. It can be haphazard, and it's hard in the relative isolation in which supervisors work. Without frameworks for understanding, interpreting experience may prove problematic, and without frameworks, they are likely to fall back on memories and disciplinary knowledge to frame and ground decisions about teaching. The point that clinical teachers are not professional teachers has been made by numerous people, so we ought to ask how well they have been prepared to meet their teacher role. The professional development that we offer tends to focus on general pedagogical principles rather than efficient and effective instructional strategies to teach general practice, i.e. linking that content to pedagogy. As well as this smattering of general pedagogical knowledge, supervisors are likely to mimic or imitate what they have seen. Unfortunately, what is called this apprenticeship of observation only gives access to educators' actions, but not their reasoning. So these memories are unlikely to enable supervisors to connect the means of instruction with potential ends, sorry. So in conclusion, PCK is a useful idea. It's a useful framework for researching, thinking about and studying supervisor knowledge. We think that it is a useful concept for teaching supervisors about teaching and learning. We think that teaching without PCK is probably commonplace in protected teaching. Is this the vision of what we want, or do we want supervisors to demonstrate more reasoned practice? There may be nothing wrong with what is happening in protected teaching, but I think it is worth challenging ourselves. Professor John Loughran, our academic partner, asked us whether we wanted to make these sessions seriously educative. I think that we do. Lee Shulman makes the point that the goal of policy is to pursue the possible, not only to support the probable or frequent. Current policy probably supports the pattern we observed. I think that we should aim somewhat higher. Thank you.
Thank you, Tim. You've certainly presented some interesting findings, and we'll open up the conversation a little bit later on. But now let's hear from the Executive Director of Queensland Rural Medical Service. Please welcome Hwee Chong.
Thanks, Chris. Good afternoon, everybody. I would like to respectfully acknowledge the traditional owners of the land on which we meet today, the Larrakia people, and pay my respects to elders past and present and all Aboriginal and Torres Strait Islander peoples here today. So, I'm Hwee Chong. I look after the Rural Generalist program for the state of Queensland, as well as Queensland Country Practice. We are a service that's part of a regional hospital and health service in Queensland, the Darling Downs Health, and we are based in have offices across the state, primarily based in Toowoomba and in Brisbane. Today I'm going to talk about the program we've developed in Queensland based on the Commonwealth funding to allow interns to rotate to rural general practices across Queensland, and what that means for the development of our rural general practice workforce and our existing and very successful rural generalist program. And also have a discussion about how you can become involved in having rotations to your general practice if that's something that interests you. Just to provide some background, so if you recall, in 2015, in December, the Commonwealth announced that there would be an integrated rural training pipeline, and this was a competitive tender application process whereby the Commonwealth were going to fund 60 places comprising of 240 accredited intern rotations. So they had two funding rounds. We applied at the commencement of the application in 2017, and we managed to successfully be successful in that application process, and we also applied in the second funding round. These intern rotations were designed for interns working in RA2 to RA5 locations, so not appropriate for interns working in metropolitan hospitals to be rotating to general practices in metropolitan or rural areas. This funding initiative, aside from funding interns to go into GP rotations, were part of a larger strategy which also developed funding for the regional training hubs, and there was an application process for that. So that was university and rural clinical schools to assist in coordinating rural training opportunities for doctors at all stages of their medical training, and that includes hospital specialisations. as well as having the specialist training program, so that was funding specialist training places in hospitals outside of general practice. So what is the evidence about rural immersion influencing career choices? There's been lots of evidence done by rural clinical schools in Queensland, and of course evidence developed through the MABEL study, the 10-year longitudinal study based out of the University of Melbourne. So I've just got a quote there from the team looking after the MABEL study, led by Matthew McGrail, who now works with University of Queensland. So there seems to be a strong association between rural general practice vocational training locations and subsequent rural practice location, further strengthened when combined with the doctor coming from a rural origin. And so that was the topic of today's debate, of course, was about career pathways and rural immersion versus do you have to be born and having an origin in rural? It looks like there's a bit of a mix of both. So upon this evidence was why the Commonwealth looked at funding more intern places in rural general practice. The program we developed was based on very strong partnerships, and I believe that's why we're successful to get the funding from the Commonwealth. So there's lots of people that were involved, starting from the very top, Queensland Country Practice, so that was my team. Aside from looking after having a responsibility for the statewide rural generalist program, Queensland Country Practice also historically provided relievers from metropolitan hospitals to our rural facilities. And that's now morphed into junior doctor rotations. And my colleagues actually presented the JDocs program earlier this afternoon and the educational modules we've developed with ACRIM that were available to these doctors going into rotations in rural general practice. Queensland Pre-Vocational Medical Accreditation is the intern accreditation body for Queensland. Every jurisdiction has an intern accreditation body. We had to get support from our Department of Health, obviously the employers, hospital and health services across the state, regional training organisations who would provide education for the interns rotating into the general practices that were accredited. Our regional training hubs, which led the responsibility of doing the evaluation program, the two general practice colleges, and of course having champion rural practitioners and their practices for which the interns were going to do their placements in. So when it comes to interns, there are pretty strict requirements when you're doing an accreditation process, of which I'm sure some of you have been through now. So the AMC has the standards, and it's really up to the jurisdictional body to accredit against these standards. So the important things are the things like governance, so who's looking after the intern, who's supervising the intern, what's the education provided when the intern rotates to the different rotations, be it GP or rotations within your hospital. How are they assessed and how do they get feedback so they can improve? How is the intern education program monitored and evaluated for continuous improvement of the education? And what sort of experience will they be getting when they go and do these rotations? So if you recall, interns have to have 3 core rotations. Emergency, surgery and medicine, and for a rural general practice or any general practice rotation, that is considered a non-core term. So that means that it's not necessary. Interns can choose to do that. It will be counted, but not in a core way, to their year of training. And with that, it also means it doesn't have to be a full 10 weeks. It could be a minimum of a 5-week term. So we talked about the governance. In terms of the governance of the program, each of the general practices had to be accredited against the AMC standards by our accreditation body. Otherwise, an intern obviously couldn't go to that location. So that was something that we had to organise. The other logistics, of course, was that we held the contract for the Commonwealth funding. However, we needed some also agreement between the hospital supplying the intern of which they employed and the practice of which the intern was going to go to ensure that there was a streamlined process. That also was required for the accreditation process. Like I said, governance was part of that. And the way we developed our rotations were that there were going to be 10-week rotations, and not 5 weeks, because by the time you get the intern and teaching them how to do the stuff, they'd basically disappear. So that was bothersome, and that's the feedback we always get with interns rotating to any terms, even in hospitals. Really important to note that that agreement also covered indemnity. So, of course, if it's an employee of the hospital and health service, they would be indemnified going to the general practice. That was raised as a concern by some of the practices involved in this program. The interns were receiving education through modules that I described before that we had developed with ACRM, and so those modules helped to cover topics like understanding working in a rural and remote context, digital health, so how to use the computers and things like that, population health, ATSI health, and there were also supervisor modules for the GP supervisors. In addition to the education provided by that practice, the medical education unit of which they were associated with, that was provided by the hospital they were employed to, each intern also is going to receive two 1-hour case-based discussions provided by the regional training organisations. So for us, that's GPTQ and GMT. So in 2018, we had 3 successful sites with rotations starting from term 1. So here they are, 3 rural general practice champions and leaders. I believe they're all here at the conference, so if you'd like to talk to them about the experience that they had, I'm going to present next some of the evaluation findings from the interns going to these locations. So we have Sue Maisel and her practice in Gundawini, with the intern being provided by Toowoomba Hospital. Bruce Chater with Theodore Medical Centre and Ewan McPhee with Emerald Medical Group also have 1 intern each, and they rotate out from Rockhampton Hospital. For 2019, we're looking to expand to 8 other sites. So this is part of our application 2 to the Commonwealth. So you can see on the map here where those locations will be and which are the providing hospitals. So, I mean, with this, there's a lot of relationships, as you can see, with the hospital and health services to assure them of the integrity of the funding and the quality of the terms going out to the general practices. I should also highlight that some of the issues that we had, so the funding that the Commonwealth provide covers the interns' wages and on-costs. It covers the supervision costs to the general practice. It covers some of the costs associated with the education the RTOs are providing, and covers some of the costs to do with the evaluation. Obviously, the health service has to be confident that the general practice they're sending the intern to meets a quality standard. There were previous relationships with the old PGPP program that were formed, but obviously there are some times where some general practices don't have registrars, don't have a very high community standing, and those are not supported by the hospital and health service to send an intern to. One of the other issues is not all general practices were happy being part of the program, although they initially said, yep, we'd love to have an intern. When it came to this is how much money is available through these funds, they weren't confident that they'd be able to provide the supervision and infrastructure to the intern. And the reason for that, of course, is the intern requires a lot of supervision, and additionally, they don't have a Medicare billing number. So that was some of the issues with this program compared to the old PGPP program where they were eligible for a provider number. So our very early evaluation findings, this is really based on some of the discussions we had with the interns going to the 3 locations this year and some surveys. These 2 interns were basically the first ones off the rank. So everyone seems to have had a good experience living and working in a rural community, or at least neutral at worst, and that there was one person that disagreed that the placement had increased the likelihood they'd be working in a rural area in the future. But that's not to say the placement was poor. Often with these doctors, well, sometimes, the hospital is the one that works out who to rotate. Sometimes that's based on the intern saying, yep, I want to go out and do rural general practice. Well, but other times, if there's no one that wants to go there, well, you're still rotated out to that particular site. So in a situation where someone's absolutely hell-bent on being a surgeon, as an example, the placement may be a very good standard and they appreciate it. However, it doesn't not necessarily change what they want to do as a career. Other questions that we asked them in our survey, you can see here, rotations increased awareness of the holistic comprehensive care. Rotations stimulated an interest in rural general practice as a career path. Like I said, the orange disagree doesn't necessarily mean it's a bad rotation. Supervisor has inspired me to consider a career as a rural general practitioner. Mostly strongly agree, but again, some people are never going to want to be a rural GP, and happy to spend a part of my career in a rural community. So this was based on 8 interns that we have had to date. So it's not a huge number. However, all of them do recommend a rural GP rotation to their peers. And some of the comments is that it provides you a different perspective, and you understand the challenges of working in a rural site and in primary healthcare, and it's really enjoyable, a great choice as an elective. So in terms of rating the rural rotation, is good to excellent for all of the interns we surveyed. A more formal evaluation is going to occur, led by the University of Queensland and James Cook University as the 2 regional training hubs. As I was saying before, we have Matthew McGrail leading the research direction from UQ and Carol Reeve from JCU. And they're going to be looking at the impacts of these rotations on the career intentions of the intern, as well as talking to the supervisors about the reasons why they chose to have an intern in their particular experience. And this is going through a formal ethics review process shortly. So I was just going to share with you an experience of one of our interns that had rotated at the start of the year.
I think it's a fantastic initiative. I think that primary care, like any of the number of specialties that we rotate around in junior doctor years, is a specialty of its own, and it's one that we're going to continue to engage with no matter what specialty that we choose into the future. I think doing it in a rural setting is a fantastic opportunity for junior doctors to gain more experience and I guess see the more longitudinal care of a patient. Obviously GP just allows you to do that because you get to follow up with patients regularly. However, by being in a rural setting, by also getting some hospital experience in that mix, you do get to really feel like you're part of managing the medical care of an entire town, which I think is an invaluable experience. And I certainly would recommend it to any junior doctors in the future, no matter what specialty they were choosing, as an opportunity to not just experience general practice as an opportunity to find out whether that's something that they might enjoy, but also as a way to further your skills, realise the importance of general practitioners, and also, I guess, the interaction between patients, the healthcare system and their GPs.
So she didn't say it here, but it's also really important to note that the way she practices now in the emergency department is different after doing this general practice terms. So even if this doesn't motivate you to want to be a general practitioner or necessarily work in a rural location long term, it helps to breed a better understanding of the continuum of care that the patients have to go through and that journey from general practice and primary care into hospital care. And she now thinks more strongly about, hey, when I discharge this patient from my emergency department, what does that mean when they have to go back to see their general practitioner, and how is that relationship?
I think it's a fantastic...
Sorry. So in terms of creating our future workforce, the rural primary care experience does lead to positive changes in interns' understandings, as I've just described, in rural general practice. And according to our very, very small number of survey findings, does increase the likelihood they'll consider working in a rural area in the future, and they've got that more holistic, realistic understanding of what happens in a rural health location. One of the other takeaways is the integration to do this relies on a really good relationship with the hospital that you're getting the junior doctor, the intern in this case, from, and an understanding of what the educational needs are when the intern goes into the general practice setting, and knowing that the hospital can't necessarily provide that because they're not in the business of providing primary care and engaging with the RTOs to help provide that appropriate education. We're working out right now in Queensland, how does that align with our Rural Generalist program? So our program recruits from internship. However, because there's not many general practice rotations, how do we get that exposure at an intern level and a PGY2 level? I know some other jurisdictions have them funded from the state, but the only ones we have at the moment are these three, expanding to the further 8 in 2019, that have been funded by the Commonwealth. So what does this mean for the future of this pre-vocational training? Certainly, it'd be great if we had more rotations into general practice during the internship and PGY2. The Commonwealth are already talking about expanding the program into postgraduate year 2. And potentially, I think, even including junior doctors rotating from a metropolitan hospital. I think what we talked about before on the debate, from this morning's breakfast, was the AMSA representative highlighted that just because we want more training to be occurring in a rural location doesn't mean we should lock out opportunities for doctors working in a metropolitan location. So that's something that I think the Commonwealth could expand the program to in a situation where we can't get enough doctors available rotating from a regional hospital. So we could approach Royal Brisbane Hospital or the PA and get those doctors to rotate to a rural general practice. I'm not sure what this is going to look like as well with the proposed changes to internship, with a review that occurred actually several years ago now, and what that means for more general practice rotations, but certainly that's something that we'd be supporting. And I guess lastly, with what's happening with having a national rural generalist pathway, does that mean there'll be some funding available as well to expand the program, or having a mandatory rotation in PGY1 or 2 into general practice? And that remains to be seen. So really, there's more funding opportunities that will arise, and in actual fact, in Queensland, we do still have some positions, some funding available. So if there are any general practices that want to take an additional intern or are interested, please talk to me about it in Queensland, of course. One of the bottlenecks is actually getting doctors released from the hospitals to rotate, because there's lots of operational issues about making sure that interns get their core terms, but it's much easier if you have a PGY2 because they don't have to have 30 weeks of the year at a hospital. Really, you have to collaborate for success. You can see we had a lot of people involved to get these applications up and actually operationally working. And a great rural primary care experience in internship can actually stimulate an interest as a career as a rural general practice. So I think the moral of the story is let's try to work together so that we can get these rotations happening in a way that's quality and safe and a wonderful experience, so that way we can motivate our future workforce to want to become rural general practitioners and rural generalists. Thank you.
Thank you, Hwee. I might take the opportunity, if I might do it now, if Megan, if you want to say a few words at all, or I can open that up to the floor, if there's nothing you want to say. Are there any questions from the floor for our panellists? I'm quite happy to open up with one or two. I think there's some interesting things that have come up. One of the comments just made before, that it says a valuable opportunity that warrants investment, was on the slide. What are the next steps for that? And that was a point that was made in the breakfast this morning. You know, that it's about getting the investment. So what are the next steps to get that investment? Who wants to answer that?
Oh, sorry.
Well, the microphone, it's on.
Sorry, I thought I answered that already. I guess part of it is influencing what's going to happen with the national rural generalist pathway, and if there's opportunities to get some more funding there. But certainly I'm hoping the formal evaluation, if we present that back to the Commonwealth, there'll be renewed interest in further investment in those general practice rotations.
But is it getting groups to, who are the groups that need to put the pressure on in order to make that happen? Like, where is that pressure going to come from, really? Is it just from rural practitioners? Is it from industry groups? Is it from ACRM? Is it from training? Where is it that really has to come from?
That's a good question. I mean, ultimately, some people on the floor might have a better answer or some comments that they'd like to make about this. I guess some jurisdictions already fund some of their general practice rotations. Part of that was because they needed other places to put their interns in, and they had too many interns. Certainly that wasn't the case in Queensland. So from our perspective, it's more having enough interns in hospitals or junior doctors to rotate out. One of the issues we're having in Queensland is we don't have enough junior doctors at the moment just to provide service in the hospital, so it makes it very difficult to release someone to do what would be considered non-core service work, because it's more of an educational experience. So aside from, money can fix everything at some point. So, but who's, as in, if you provided enough funding to compensate that. But if you're asking the question, who puts that pressure, I think it's a policy question. So right now it'd be the same. So advocacy groups, so organisations like the colleges, like doctor representative groups, rural communities to say, okay, well, how can we get the Commonwealth to fund more educational experiences out here?
Can I just throw a quick, is there anyone with a, yes, up the back there, if you wouldn't mind, I don't think we have a microphone there. We did have one, but if you want to speak loudly, I'll repeat the question. Hello.
Okay, I honestly can't say, because I haven't asked the supervisors or the practices if they have experienced a difference between the old PGPPP program and the new program. I just know that there were some practices which, from a financial viewpoint, were not happy when they crunched the numbers. Oh, look, Wendy McPhee's here. Yay, and she's put her hand up, so she can probably answer that question.
When, you've got the roving mic. There you go, Tim. Thank you. 2, 2, 1, 2. There we go. I knew the roving mic was hiding somewhere. There we go.
Hi, I'm Wendy McPhee. We have one of the interns, or one of the intern rotations in our practice. We have found that they do get provider numbers for refer only, so they can refer to radiology and pathology. They can refer off to specialists, and that didn't happen in the first intern rotation, but Rocky Hospital has got organised after the first one, and the subsequent interns have had refer provider numbers. They just don't have a billing provider number. So what we do is we schedule one of our senior doctors to be their supervisor for the day. Every patient is reviewed by the senior doctor at the end of the consultation, so before they leave, and the patients are bulk billed under the senior doctor's provider number for his part of their consultation. So it's generally only a 23, even though the intern may have spent 45 minutes with them. But the supervisor does review every patient before they leave. That allows us to give a bulk billing option to our patients as well. If they're not concession card holders but they want to be bulk billed, they can book in with the intern. It will be bulk billed. They do know they get reviewed by a senior doctor, but they get to see the intern first. So it's worked very well in our practice.
Yeah, go to me. I'm standing. You're standing. Yeah, I'm close. It's easier, isn't it? Can I just play devil's advocate? And if I get people irritated and upset and fired up, then that's so be it. That might be interesting in itself. I've not experienced having interns in general practice. Plenty with registrars, plenty with medical students in various different sorts of settings. the description that you're putting to me really is no different from having a final year medical student. And I'd be kind of interested in you responding to that, or anybody else that has. And then the inflammatory potential bit is perhaps interns really have no place in general practice because they don't actually have enough experience. It's a complex, multi-dimensional, multifaceted game that we play. Perhaps we should be getting them when they're a little bit more mature.
Eddie's throwing a cat amongst the pigeons. Does any of the panel want to make a comment on that first?
Oh no, I'll leave it to Matt because
Okay, Matt.
he's got an intern. This is great.
I'm Matt Maisel from Gundawindi, so we've been involved with the program this year, and I had the same concerns. I've had the same concerns for several years, which is why I left it to Sue to organise everything and do all the hard work. And I was really the devil's advocate for her, but having had, I think, fortunately, several very good interns, and not every intern's going to be the same. But I can tell you it has actually been different to having medical students. And clearly, you know, the intern doing their first term is going to be more like a medical student, but the intern doing their fourth or fifth term is quite different to a medical student, as you can imagine. But just practically, they can, by the time you get into the room, we insist that they don't just come and tell us, you know, what the history was and what their findings were and ask us what to do. They go further, they work out a plan. So we get in there, they've not only worked out a plan, hopefully, but they will actually have written the referral letter if it's appropriate. They will have done the scripts. They will have given the patient, you know, some education. So no, in fact, I think they're more than medical students. And I think they get a lot out of the experience because it does really teach them to look at multiple problems, holistic medicine, and I don't think the complexities of general practice are too complex for them to get a good experience. That's just my experience, right?
I guess if I could just make a comment, I think it's been really interesting reflecting on the intake into AGPT over the last 3 years, and I think some of the reduction we're seeing in applications to AGPT has been as a result of that lack of exposure to general practice in PGPPP when it existed. So notwithstanding, I think, the issues that you've raised, which I think are really valuable, I think, you know, looking at this exposure in the context of giving people that opportunity to experience general practice where otherwise, you know, they would only see hospitals as a career. I think it's worth bearing that in mind as well.
So my question probably relates to your question just before. Is the initiative for this program a Commonwealth program, or is it a state initiative, or for the program that you're running at the moment in Queensland? Is the initiative from your health service, or is it from a Commonwealth program? Or?
Commonwealth made the funding available, but you had to apply for it. So different places have approached this differently, as in different states and territories have approached this differently. There are some general practices that said, hey, I really want to have an intern, but you have to have the intern come from somewhere. And the strength of ours was having a statewide approach. So I'm a Queensland Health employee. I engaged with the Executive Director of Medical Services, so the medical professional lead for each of the hospital and health services, of which we have 17. And there was a process to say, okay, who is interested in being part of this program? Because they had interns before in PGPPP. Some of them were more supportive than others, but there were some changes, as we alluded to, and we weren't sure how that was going to work out. The universities were very keen on supporting it. The Department of Health, they don't deal with operational things, but they said, hey, sure, if you want to pull this together. So maybe it was just fortuitous that we were in the situation that we were in. Some of the other jurisdictions that applied may not have been as successful. I think I'm led to understand Queensland has the most funded positions out of this program because of the strength of our application. And you had to make it work for the budget as well. So there's a budget, like anything, if you want Commonwealth money, to produce back to them, and it was a very fixed number in terms of the ceiling of what they would provide you to be able to pay for the cost of the intern and supervision and the other costs that you had. So I think it's a combination of both. Commonwealth made the money available, but you as a state had to kind of sort your stuff out, so that way you could put together a good application.
Just some observations too. I was involved with the PGPPP for quite a few years in the East Arnhem area, and I haven't done the intern sort of rotations, but the more junior the doctor, I found, worked better when they had already an active interest in general practice. And then when you got the PGY2s and 3s and so on, it was quite useful, even if they didn't have a real active interest in general practice. As you say, they did learn what it was like when they were going about other pursuits. So you know, they might want to do anaesthetics or they might want to do obstetrics or something, but they were better when they were in their big base hospital for the experience they'd had in general practice, much better. But they're very young ones. It was, in some ways, if they didn't have an active interest in general practice, it wasn't as useful an experience.
I do agree with that. I mean, I think I mentioned that the hospital's the one that works out who to rotate. You're not always going to send someone that is interested in going, but it's about providing a quality experience, and some of that will change their mind. At least they'll understand primary care better, or the rural context a lot better. And we didn't ask the hospitals, because it's up to them operationally about how they work out which interns to be able to send. I should also add that it's not just the quality of the experience, but things like accommodation, the basics, making sure you got internet and things like that. So there's a lot of in-kind support as well from universities or the hospital to put them up in accommodation when you go out to those rotations. But I'm sure that you're familiar with that. Like, that happens in every junior doctor or some of the nursing staff rotations or placements that you have to provide.
Could I just direct a question to you, Tim? If we can sort of, I guess, talk to the registrar training, supervisor teaching. Do you have suggestions on, I mean, we're talking about quality of supervisor teaching, I guess, of registrars. Do you have any suggestions on how to help supervisors be better teachers rather than just content providers?
Yeah, thank you. I've got interested as a result of this project in the professional development that we do for...
Tim, I'll give you this microphone here.
Yeah, I've got really interested in the professional development that we offer our supervisors, but also our medical educators. And one of my favourite papers that I've read is called Professional Development, a Great Way to Avoid Change. And it looks at the sort of types of things that we offer educators, typically the kind of workshops and you know, one-shot sessions that we do. And most of the evidence, if we didn't know that already, shows that it makes very, very little difference. So much of the education that we do as a training organisation, if you look at the evidence, it's not going to make a difference. So we need to have a look, go and have a look at the kind of evidence-based education for the types of things that makes a difference for our... education of supervisors, yeah. So I'm currently, we mandate 6 hours a year for our supervisors around teaching. Many of our supervisors would complain that they sat through the same things over and over again, and we keep running the same things over and over again. So we need to really rethink what we're doing. One of the research project that's actually sort of come out of this sort of project, which again is funded by the college, is something called a video club. And we've just sort of started trialling this, where we've got 2 groups of supervisors. One are meeting online. They're meeting once an hour every month. They're recording their teaching and they're showing that teaching to their colleagues and using that teaching as a basis to discuss learning and teaching. And one of the key things that we do know from the literature that works is that you actually need to have things that are sustained over time. So coming along for, a day just doesn't work. So these regular meetings that we're going to run over a sort of series of time is something that we're trialling to see what it works. But we need to have a look at the literature, I think, and do something differently.
Just on that, can I make a comment then? If you made a comment earlier that supervisors are being more supervisory, so two things came from something you said. Have we lost the want to be academic over being vocational? And is kind of in terms of supervision, monitoring and assessment, is personal bias of the assessor a challenge?
Say the question again.
Is personal bias of the assessor a challenge?
In teaching or assessing?
In teaching.
Well, I suppose I suggested in my talk that, is it personal bias, that much of the teaching we looked at was habitual. So that's, if it's habitual, then it's unthinking that people were using the, I don't know whether
and that would be a personal bias then, if it's unthinking.
I don't think that's necessarily a bias. You just end up doing what you.
Well, it frames your conditional thinking. So if your thinking is actually being framed by the fact that you're bored or you don't like it, or it's it's just repetitive, then it would suggest that you're not invested in the process. That's my kind of interpretation.
I don't think it's a bias in a way, but you are choosing things that you're comfortable with, and then you're using them unquestioningly.
Okay. I think we've kind of covered everything. Any other questions? No, I think we're done. Yes, one more. Hello. No, that's all right. If you want to give me the microphone.
Hi, sorry, I'm Grace. I'm a final year registrar, so obviously very interested in high quality teaching, having just come through as a registrar. One of the things that I have been interested in, and I'm now working as a provisional SMO, is that I'm now supervising junior doctors, including interns, and I'm just wondering if I don't know if you spoke to it already, I'm sorry I missed the first part of your presentation, but whether teaching supervisor skills could be part of registrar teaching, because we're going to be supervisors down the track, and teaching us to be teachers, because we are often supervisors of medical students in general practice. We have a student sit in with us, and learning to teach them might help us to then be better supervisors. I don't know if that's part of any framework in anyone's sort of long-term plan. So is that something you've already spoken about? I'm sorry.
No, I think it's a good question. Here we go. Hang on there. Let me do this.
I mean, there may be some people in the room who can answer that better than me. I mean, what I do know is that undergraduate medicine, some courses are including, becoming a teacher as part of that undergraduate medicine. And I know that both of the colleges have also made that a kind of priority of, doctors as teaching. And we're meant to do something that as an RTO as well, but I know it's marginal. I suppose that's what I was sort of hinting at, that teaching is actually a whole other profession, and we're asking, doctors to be really good teachers on top of that. So I think there's a whole range of things that the universities could do, that the specialist colleges could do a little bit better, to give clinical teachers the skills that they need to be excellent. A lot of them are doing a really good job. I didn't want to go away think I was bagging supervisors, but I think we could improve, what we're doing.
Well, for a mixed bag of conversation with training and rural generalists, I think we came to a fairly decent outcome. So an engaging conversation. Thank you so much. Could you please join me in thanking our panel for joining us today? Thank you to Hwee Chong, to Dr. Tim Clement and Megan Carl, the Rural Workforce Agency's premium sponsor. That wraps up this particular session, and I think that wraps it up for the afternoon.